that we will go back to all the comments to the chat box and then go through them and also send information to everyone, really with a recap of all the comments in the chat box. And please also be aware that the meeting is recorded, and that by staying in this webinar, you are agreeing to the recording, or to being recorded, just for your information. So let's move on with the exciting agenda that we have today. And actually, for me, really, as the person leading the rehabilitation program at WHO, there has only a couple of points regarding the rehabilitation response at WHO. And going a little bit a step back is what we have experienced during COVID. It is a situation that has brought to the surface and really make visible for everyone. First, as my two colleagues also said, that rehabilitation is fundamental along the continuum of care, in acute care, post-acute care, and long-term care. And we have that, and COVID-19 have brought it up into the surface that is the case, because patients with COVID-19 have needed this care. Another point that COVID-19 has brought up is that there is a tremendous large number of people who need rehabilitation. And this has been brought up by the fact that in many countries and in many settings, rehabilitation has been discontinued. And we know that many people around the world have been deprived of the rehabilitation they need during this period. For example, we know, and that based on a survey that WHO conducted, that at least 60% of the countries have experienced disruptions in the provision of rehabilitation services. And we have been seeing news, and we have been seeing reports and also literature providing information on the consequences for those people needing rehabilitation. So to a certain extent, we have really, in this situation, that is a situation of crisis, we also have an opportunity. We have also the opportunity to bring into light the essentiality of rehabilitation in the continuum of care and also in the health system. Today, we will concentrate in these two aspects of COVID-19. On the one hand, the provision of rehabilitation services for people with COVID-19, and on the other hand, what can we do, what have been the consequences, but also what can we do when rehabilitation services has been discontinued. Also from the perspective of WHO, this has been the strategy of the response. So on the one hand, what we have done is to make sure that rehabilitation is included in all our clinical guidance. And if you go to our clinical guidance documents, to the clinical about the clinical management of COVID-19 patients, but also the managing of essential health services, you will see that rehabilitation is an integral part of it. We have, however, also put an accent on really creating also documents that address the issue of the discontinuity of services and how potentially we can address that discontinuity of services when rehabilitation services are needed. Without further ado, I would like to turn now to our fantastic speakers that will really guide us through this. First, we will start with our colleague from the Afro region, John Appiah, who is working in the case management pillar in the African region. Now, John, you have the floor. Please go ahead with unmuting yourself.
Thank you very much. Good morning, good afternoon, good evening to all our cherished listeners. Thanks for the opportunity to be able to discuss case management activities on the continent with the Afro member states and then also EMRO member state. Next. So outline of the presentation, I'll try and keep it simple and then stick to time. Basically, we'll be looking at the current situation in these two regions, updates on current case management, and then summary response. And we will look at priorities and next steps. Having done that, I'll conclude for other speakers to come in. Next, please. Yeah, so the objective of management is overall to provide safe and effective clinical care. That's, we're talking about both access and then quality. Access in the sense that in pandemics, we talk about the health resources being able to take care of every patient. And when we talk about flattening of the curve, that is exactly what we mean. But with pandemic and large number of cases, sometimes or most of the time, the system is overwhelmed and the system is not able to manage cases as they needed. And this will compromise the quality of care. Part of the job is to have a quick assessment, mapping of resources on the continent to ensure that we have enough treatment facilities, we have enough equipment, we have enough oxygen, we have enough human resource in terms of healthcare workers to be able to do this. And that is an integral part of what case management is about. And on both, in both regions, we have a fair idea of the capacity to handle COVID cases on the continent. It's not a pleasant situation, but we are managing. We also work on providing guidance for countries to support care. So what headquarters does, which we join the guidelines, we are part of the guidelines development group to develop guidelines as we get information. COVID is a new disease entity altogether, and we are learning from it as and when new things comes in. So you realize that we keep on updating, and that's what we do. The other aspect is that, again, it's a new disease. We need to support training of healthcare workers. We need to make sure that health workers have been transformed. They have the knowledge, the updated skill based on current evidence to care for patients. And then we also provide technical and operational support to country offices to ensure that they also, in effect, also transfer these technical supports to the countries. So that if there are issues, specific issues that a country will need, they come to the regional office, they come to us, and then we provide a technical operational advice. Partnership is quite important. We can't work on our own. We are more of a technical organization. We need implementers. We need others who are collaborating. And with COVID, we can only win if we work together. We can't win as an individual entity. And that partnership and collaboration is quite important. Next slide, please. The current situation on the continent in Africa, as at 13th of July, we had 474 1,592 cases, and but just about 52 of them have been declared recovered using the recent WHO update. We have quite a number of health worker infection, which is not pleasant, but it's part of the job, and we need to work to reduce the health worker infection. The current case fatality rate is that we've had 8,210 deaths. And out of this, we calculate, and then we can say that the death rate is about 1.7%. On the right side, you see the table with countries actually driving the kiddies case numbers on the continent. South Africa actually is contributing just over half of what is happening on the continent, as you can see here. It doesn't mean that the other countries are not suffering. The others are also going through similar experiences. Their system is slowly becoming overwhelmed. So basically, this is the picture we see on the African continent. Next slide, please. The current situation in the African region in terms of age and gender. So COVID has more or less been seen as the incidence is high in the male gender, as you can see from here. Next. For severity of illness, even though we don't have cumulative number of cases, we don't have that evidence, we lack the data to put that together. But from a few countries that were able to collect this data, you realize that mild to asymptomatic to mild cases amount to, in the situation of Malawi currently, for more than 96% of cases are either mild or asymptomatic. If you look at Seychelles, something similar to your right top corner, also 96. If you look to the right lower corner, Sierra Leone, 62% are either mild or mild or asymptomatic. And part of this is the ability to test. Those who test more might have a bit more mild and asymptomatic cases. But doesn't mean that the system is able to hold on to all of them, to help all of them. Next slide, please. Current situation in the Mediterranean region, Eastern Mediterranean region, as of 14th of July. And this is based on country report. Cumulatively, you have 1,312,066 cases. 73.2% of these cases have recovered, with deaths of 32,092. This also giving a median age range of a case fatality of about 1.8%, which is similar to what we see on the African continent. To our right, we see the table there gives an idea of the countries actually driving the incidents on in the Emro region. Next, please. Similarly, slightly it's the same picture, but you see a little bit more higher incidence in the female population. Something else which we all have to notice that, yes, we know that the disease actually is affecting the older age group disproportionately in terms of mortality. But then the large number of people being infected are the young adults from 18 to 50 years of age, 40 to 50 years of age. And then subsequent, beyond that, beyond 50 years, that's where it takes its major toll in terms of death and mortality. But we know that this large group will come out, who also experience other debilitating effect if we take death out, including those that will need rehabilitation services. The numbers have increased, and we need to pay attention to that. Next, please. Interventions to reduce mortality. We need to work on our risk communication and community engagement. You all know the rumors and then stigma and other things that comes out with COVID. There are instances, places where those who have recovered are actually virtually barred from going back to their community. people are stigmatized, and that's what we need to work to avoid. Prevention and infection control, very important in this case. We know how COVID is transmitted, and all of us will have to work together. In our health facilities, the stress is on our health workers, including rehabilitation colleagues who work in these areas. There are a number of colleagues who have been infected. Some of them, unfortunately, have died. To be able to do this, we need to stick to the non-pharmacological prescription of reducing healthcare infection. We know that transmission is driven in hospital among health workers, mostly by health workers. If you look at the picture and what is going on, what has published and what we know, infection among healthcare workers, including rehabilitation workers, is because we are not sticking to the recommended infection control practices. So please, let's look at the distancing, mask wearing of masks, and basic things, hand washing, to ensure that things are done. There need to be continuity of services, and specifically to case management, we need to look at risk groups. There are some comorbidities we know have been associated with deaths. We recommend that early identification, very important, so that you can monitor and initiate treatment early. Home care will have to come in here. Oxygen therapy is the cardinal point in managing cases with COVID. Again, rehabilitation therapy, right from the time the patient is admitted, is highly recommended. You hear about prone position and so on and so forth. You don't need to get to the point where prone position, even alive, is needed. We need to work right from the point the patient is admitted to the hospital to ensure that the respiratory problems that's associated, respiratory and other problems associated with that, is taken care of. The gaps and challenges, the real-time issues with borders closed. We cannot have on-site training. Because of that, we have to make use of virtual webinars. We need to cascade those who are trained online, should cascade a training back down to where they were. Continue with that cascaded training so that many more colleagues will get this skill and knowledge. We've mentioned health care worker infection already, and health facility. We have very limited facility in terms of ability to take care of surge capacity. Not only do we have limited facilities, but we also have limited healthcare workers. So the little we have with us, we need to ensure that
John, I have to tell you that you have 1 more minute.
Okay, next slide, please. I'm almost done. So
you are done. Fantastic.
Thank you very much.
Actually, it was a fantastic overview, and actually already responding to the questions that were submitted with the registration, because many people were indeed asking, what is WHO doing? So it is really good that you put this perspective also in your presentation. Thank you for that, and really that you emphasize also the issue of working together. So let's now move to our next speaker. And this is Gail Smith. And Gail is, works in the UK Emergency Medical Team Global, and it is a emergency rehabilitation specialist. Gail has broad experience in low-income settings and in the context of outbreaks. And she has worked with Ebola in Sierra Leone, and also been involved in many other work in many other countries. We also had the privilege to really count on the knowledge of Gail when developing our technical work here at WHO, and also integrating rehabilitation in all the clinical guidance that you have seen. And Gail, you will talk about rehabilitation for severe cases of COVID-19, and you have the floor. Please go ahead.
Many thanks for that introduction, and it was a real privilege to be able to work on these documents with the WHO rehab experts and also other members of the UK EMT rehabilitation specialists, so Zoe Clift, Pete Skelton and We had Dr. Bronwyn Connolly from Queen's University Belfast also with us on that, which made those documents possible, and they were introduced earlier. So I will be just focusing more on the rehabilitation fitting into the clinical management of COVID-19. That follows the guidance that has been published and is accessible. The link was in previous slides and will be shared later. But looking at the anticipated rehabilitation needs in the acute, subacute and long-term stages. Thank you, well timed. As we know, the COVID-19 patient presentation can vary, as can that severity of illness that has already been mentioned, where we are aware that the greater illness severity may actually require not only hospitalization, but can be complicated by respiratory failure and other multi-organ failure, which result in a possible need for ICU, so intensive care unit admission, with likely invasive mechanical ventilation. It is the complications that are associated with being in an ICU, receiving invasive ventilation, sedation and paralysis and other types of therapies that can actually then lead to this necessary prolonged immobilization. But the consequences of all that is where rehabilitation really comes in key. Next slide. So with that in mind, and looking at that ICU environment, the likely impairments you will encounter will be related to physical deconditioning and muscle weakness, impaired lung function, delirium and other cognitive impairments, impaired swallow and/or communication, mental health disorders and psychosocial support needs. In the longer term, there are many aspects of post-ICU syndrome, so PICS, that may also present in this ICU population. So it's really important to remember that each patient will present with individual problems and different levels of severity, and we need to be able to assess for these and manage these appropriately. That is only possible if you're using a multidisciplinary team to that MDT approach, and using your specialists in speech and language therapy, occupational therapy, psychology, dietetics, so nutritional therapy, and physical therapy. There are still many unknowns related to the pathophysiology of COVID-19, and we are not sure how these will go on to impact a patient's recovery further down their line. Next slide. So focusing again on those three areas, acute, post-acute, and long-term. Looking at the acute, what we are looking at objectives in our management from a rehabilitation point is to optimize the oxygenation, manage any secretions, and prevent complications. It's likely the setting will be an ICU or HDU, and that input will have specialist respiratory physiotherapy skills as well as that MDT approach. We are looking to deliver interventions that will help to optimize that oxygenation and using respiratory techniques to manage the secretions, be it through positioning, airway clearance management, and even that ventilation weaning. And of course, trying to identify and mitigate against the complications that we know exist when we've seen the evidence that's come out on the general ICU population. So that physical deconditioning, problems with swallow, nutritional advice, and trying to manage those complications and prevent them, such as aspiration pneumonias, which can be huge, especially in patients with a tracheostomy. But again, this will highlight why it's important to have that MDT approach with many different rehabilitation professionals sort of inputting into a patient. Looking at the post-acute stage here, we're hoping that patients' levels of sedation have been weaned, so they're actually able to engage a lot more. And it's really, really important to make sure your patients are engaging and that you're goal setting with them, but also their families if you've got contact with them. So objectives here will be to identify and manage the impairments for affected functioning domains. And those domains will include physical, cognitive, mental health, swallow and communication and nutrition. Again, showing that it's a wide range of domains that we'll be working in. That rehabilitation is not just physical, it covers a huge aspect, and there is that need for an MDT approach. Again, your setting will be rehabilitation wards and units, possibly step-down facilities, but actually in some circumstances this may be a home environment. Really important to make sure you're progressing functional rehabilitation as able, trying to normalize a patient's patterns with day and night routines, and giving them exercises that they can work on and sort of take ownership for a little bit, as well as their sort of joint rehabilitation sessions. Longer term, you're looking at optimizing the function, minimizing impacts of impairments on independence and quality of life. So that can be sort of their day-to-day routines and responsibilities, but also ensuring they're able to get back to work and or education for some of the younger patients that are presenting with severe COVID-19. The sort of facilitating safer discharge and onward referral, which in the post-acute, which is a huge part of rehabilitation, feeds into that long-term actual fact, making sure those impairments that you flagged up before discharge are being addressed by specialist input into the right services. In that setting, these services may actually be things, services like pulmonary rehabilitation, peer support groups, psychosocial support groups. Really, really important here to emphasize that actually this is where telehealth and telerehabilitation may prove quite effective, as it may be the way to ensure timely follow-up of these patients, given the strain on health services overall and the need to minimize transmission risks and adhere to your IPC measures that may be in place in certain clinics. As mentioned, there is a need for these follow-ups. There is a need for follow-up clinics, and these clinics have to be determined at a service provider level and have to include rehabilitation staff and an MDT input. So something to be thinking about now before the surges happen, before your wards and hospitals are filled with patients, looking ahead, looking at what these patients may need after they're actually discharged. Next slide. I also just wanted to take a moment to think about areas where critical care facilities are limited, where ICU and HDU facilities may not be present, or the ceiling of care available is oxygen therapy only. There is a huge importance that rehabilitation can play in these settings. You can prevent physical deconditioning, assist in positioning for better ventilation, but also that pressure sore prevention, giving patients advice on positions and techniques to manage their symptoms. Again, this nutritional need, there has been a huge nutritional depletion in these patients because of their reluctance to take in fluids and nutritional, providing much needed psychosocial effect as well. Sorry, I seem to have lost the slides from my screen. If that's, I'm not sure how it is for everyone else.
Yeah, also lost here.
So let me try to get them back, because actually I didn't change anything.
I'm happy to keep talking.
Keep navigating us through that.
But again, and even in a setting where you maybe don't have as many ICU and HDU beds and patients are being managed on general wards, rehab staff play an essential role in that safe and timely discharge, to free up your beds, but to make sure patients are going home with information to start their recovery process, and again to plan their follow-up. Make sure as they leave your facility that they are not being lost into the community and not being followed up. The other considerations sort of relating to patients I just wanted to talk about was that older people and people with comorbidities and or disabilities are more vulnerable to the impacts and impairments of COVID-19 illness. Hence why it is this discharge is being aware of these groups that are often probably more restricted their ability to even access telehealth or to possibly travel to follow-up clinics. Be aware of them, try and think ahead of ways that you could possibly help them through this, be it through the use of the WHO leaflet that has been provided, that there's something that you could possibly give patients on discharge to have at hand to be able to sort of start the recovery process in an informed way, if sort of access to telehealth, to phones and other platforms for ongoing remote support might be a little bit harder for them to access. Again, we've mentioned that there are many unknown long-term effects and impairments of COVID-19, and a lot of these may actually only be identified and flagged up on these follow-up appointments, on these follow-up phone calls that you have with your patients, and they're really, really important to sort of think about now and try and plan ahead so you know how that's going to happen in the months to come. A little bit more of a sensitive area is that there is a stigmatization of people who've been hospitalized with COVID-19. it was seen in other outbreaks and is present and has started to sort of show up in patients that are going back to their communities having been unwell and treated for COVID-19. And a lot of that is a fear from these communities of something that they don't understand. And so I think it's really important that there are many roles here that we can play as rehabilitation staff, we can play as social workers, I know, and community health staff, about that community engagement, making sure that the right messages are coming across, and that if there are fears and questions, that they can be answered appropriately, so that these members, when they're returning back, aren't feeling even more isolated after being unwell with COVID-19. In terms of staff considerations, is to understand that you may have a lack of resources, or there may be areas that you feel are out with your scope of practice. Address these, flag them up to your service leads, to your health boards. Tell them what you feel are your staff, your training needs are. Tell them what you feel you are lacking in resources, and trying to address these now in a more timely fashion, especially knowing ahead that this might be quite a large group of patients that will need ongoing rehabilitation. Within that, actually, and a huge part of it is to ensure that you are actually having your own mental well-being as staff in this sort of time where you are key workers, where you are seeing these patients every day. Your health services are probably in a surge capacity, and these patients are arriving with less support. Their families are not allowed to visit, so there will be more strain and stress on you in your job, in your professional lives, but also back in your own communities and in your own personal lives. And it's really, really important that service leads and sort of service providers are ensuring their staff well-being throughout this whole process. And just to summarize, then looking back, my summary slide was just sort of pointing out how rehabilitation interventions will focus on the ongoing impairments, and these are across a huge range of domains, including mobility, respiratory function, cognition, swallow and nutrition, and communication. And for all of this to be addressed, you need the MD2 approach. It is an ongoing learning curve, a learning curve that has had a huge amount of fantastic evidence come out through this collaboration and partnership that was mentioned, through countries working together, through clinical specialists coming together, and through international groups working together and pulling up and creating phenomenal resources. And I know that World Physiotherapy and the International Society of Physical Rehabilitation Medicine are both presenting on this later. So, but please use these resources, go to them, keep up to date with the WHO advice and guidance. They are there for a reason, and they will really help you in your practice. And
fantastic. Now I have to force you to say your thank you.
That's it, that's me.
And really it has been fantastic, and despite the challenge of having to do the presentation without the slides, everyone can be reassured that all the slides will be shared. But it has been really fantastic to hear from you also based on all the experience that you have accumulated. So thank you for that. Let's move on into the next topics, what it is about consideration for rehabilitation services during COVID-19, and also the challenges that we are facing. So our colleague Pete Skelton, who is an emergency rehabilitation consultant, will introduce this topic. I have to say that I'm extremely pleased that Pete joined recently the rehabilitation team here at WHO headquarters, at least for a couple of months, and he will also strengthen the team and making sure that we integrate rehabilitation into our emergency program. So that is really good news from our side. So Pete, you have the floor, please.
Many thanks, Alakos, and thank you to all of you for joining the webinar today. Next slide, please. So as Alakos discussed, I'm going to really focus on the considerations for non-COVID services, so the normal services that we would be running that are likely to be highly disrupted by the current pandemic. Previous slide, please. Thank you. And As everybody, I'm sure, on the webinar is already aware, a lack of access to rehabilitation will compromise the health outcomes of the patients that we work with. And so I won't dwell on that point specifically, but I think it's also worth emphasizing that actually a lack of access to rehabilitation can also increase the strain on the health service that is already under significant pressure due to the pandemic. So lack of access to rehabilitation may extend inpatient stays or make it more difficult to discharge patients from hospitals, or at least discharge them safely. And where patients in the community are then developing preventable complications, it can result then in readmission or admissions to hospitals. And clearly one of the main focuses at the moment is all health services need to be avoiding putting additional pressure on hospitals. So I don't need to persuade the audience, I'm sure, but we do need to ensure that we are maintaining some sort of rehabilitation service throughout the pandemic. Next slide, please. So apologies, this slide seems to have stretched and grown beyond the bottom of the page. I don't know if those can see all the way down. Essentially, there are two factors that we need to consider when we're considering how to persist with rehabilitation services, how to sustain rehabilitation services during the pandemic. The first one is glaringly obvious, which is what is the risk of infection for both our staff and our patients? And as we've seen already from Dr. Appiah's presentation, despite IPC precautions and access to PPE, we are still sadly seeing healthcare workers who are dying as a result of this. And we know that many of the patients that we work with would fall into vulnerable categories, and so would be more likely to experience significantly detrimental consequences from COVID-19 infection. But we need to balance that off against the risk to our patients as a result of the cessation or disruption of services. And unfortunately, there is no risk-free option here. As I've outlined below, essentially, if we look across, if we consider options to us, one option is business as usual. So we continue with our rehabilitation services as they were, but that carries an extraordinarily high risk of infection, both for patients and for staff. We can then reduce services and focus on very particular patient groups, but also, as we've seen, even with PPE and everything, there is still a persistent risk in many contexts to both staff and to patients. And of course, some patients then are still missing out on rehabilitation services. We can take a blended approach, which is to adapt our services, take mitigation steps like PPE, and develop new innovative ways then of reaching some patients while persisting with some essential face-to-face rehabilitation services. And that carries both moderate risks to patients and to staff of infection and of cessation of services. We can switch to a 100% remote, so telehealth type approach, but again, risk to patients then from a lack of direct contact and follow-up are high. And we can take approaches which unfortunately we are seeing taken in some places, which is simply to end rehabilitation services. Now, obviously this will depend on the type of service, but the risk to patients simply from ending services is incredibly high, depending on the type of patient and context. Next slide, please. So what factors do we need to consider to help us to take the decisions that we need to then around services? Well, the first and most important is probably the pandemic context in the country in which you're working, or even in the region of the country in which you're working. And there is no one answer that will fit everybody. So the extent of spread of the virus, the impact of any local lockdowns on the population that you're working with, and the presence of local or national guidelines which will govern what you may or may not be able to do as a rehabilitation professional will all contribute to the decisions that you have to take around the services that you can persist with, and what needs to be adapted and what needs to be stopped. We need to consider the risks associated with stopping or reducing services, and these risks will be different depending on the type of service that we are offering, on the type of patient that we are working with and their vulnerabilities, but also for individual patients, the risks will be different. And again, we can't simply take a decision based on service. We need to also consider the individual needs of patients and prioritize based on that. What we then do will be determined by the feasibility and the appropriateness of what alternatives we have. So in some contexts, web-based telehealth systems using laptops and smartphones are very, very appropriate. In others, lack of access to smartphones or internet may mean that telephone follow-up may be required, and in others, simple approach to paper-based systems may be necessary. And there are obviously varying costs to all of these approaches, and those costs will differ depending upon the country and the context and the way in which health care is funded within individual countries also. Critically, access to PPE, the robustness of the infection prevention and control measures, and also the way in which staff are trained to adhere to and continue to adhere to those measures will determine to some extent decisions to continue services or not. And finally, the capacity of the rehabilitation workforce to actually retask and adapt to new systems and ways of working needs to be considered. Next slide, please. In terms of which patient groups to prioritize, now this again depends very much on individual and service level context. However, when we worked on the PAHO guideline for rehabilitation considerations during COVID, which Alakos introduced at the beginning, we identified some groups that we would consider to be priority groups. So those with new and acute injuries who would go on to develop serious preventable complications would obviously be a priority for continuing to receive rehabilitation services, as would patients recovering from surgery who might get stuck in hospital without rehabilitation services. Patients who are at risk of suboptimal recovery, so for example, those recovering from stroke or perinatal complications. And then critically, and I think we've seen this question raised a number of times, is patients requiring long-term rehabilitation who might experience a loss of function or develop complications if that service is disrupted. And I think there's a second layer to this, which is to also take into consideration the impact of lockdown or isolation on many of the patients that we work with. So not just the lack of rehabilitation, but the lack of other support services which may be disrupted, which would place particularly people with disability at increased vulnerability at this time. And then finally, in hospital, patients who are unable to be discharged safely, who would be remaining in hospital without access to effective rehabilitation. Next slide, please. So what potential actions should be taken? Well, certainly in terms of decisions, I think that we would advocate that the rehabilitation workforce need to be actively involved in the decisions around the rehabilitation service. So these should not be, decisions should not be taken without the involvement of service providers. They know their services and they know the patient populations that they work with, and they should be able to prioritize based on local and national requirements who they can continue to safely work with. We need to prioritize services, but also patients based on risk. And we need to always consider alternative methods of delivery for services where it's safe and effective for us to do so. PPE is absolutely critical, as has been mentioned time and time again, for those where face-to-face contact is still taking place. And finally, where face-to-face rehabilitation is not an option, we need to look at how we can repurpose the workforce, particularly those that are not working on the COVID-related response, towards alternatives. And telehealth is the obvious one, and that can consist of many different formats. Advice lines, self-management plans, increased patient education. There are many different ways that we can adapt what we do to reduce face-to-face contact or eliminate face-to-face contact, but ensure that patients are still receiving adequate rehabilitation. Many thanks all.
Thank you, Peter. Yeah, fantastic overview. Thank you for that. Needless to say that we are running out of time. We have still 3 presenters and now 30 minutes for the webinar. So bear with us. We will come to the end of the presentations. And I would like to ask the coming speakers perhaps to keep in on time so that we can close really as punctual as possible. And I apologize already for starting late and also for the lack of my capacity to chair accordingly and interrupt, but I found all the speakers so amazing, important, the discussions that are taking place, that it is really a challenge. But the next speaker is Marike Betsuidenhout, and she's from South Africa. Let me only tell her from her that she's someone passionate, and out of passion, she founded the Rural Rehab South Africa, and she will present that, and we will present to the both perspective in the context of COVID-19 or the rehabilitation for COVID-19 patients, but then also for rehabilitation services in general. Please, Marike, thank you for being with us. You have the floor.
Thank you, and greetings from South Africa, which is often termed a world in one country. So without ado, I will start in the interest of time. So the impact of COVID extends far beyond the narrow medical model and the immediate acute and the sub-acute rehab needs of patients. The economic and social ramifications of this pandemic are massive, and they're going to be long-lasting. South Africa is already one of the most unequal societies in the world, with socioeconomic and regional disparities affecting health outcomes. The bleak economic outlook for the country over the next few years suggests that more people will be forced below the poverty line and become reliant on public health and welfare services within a severely constrained economic environment. This has implications for 84% of our population who currently rely on a fragmented and inefficient public health service, which is currently buckling under the strain of COVID and years of austerity measures. For the majority of people with disabilities, accessing care already results in catastrophic health expenditure, making retention in care a significant challenge, especially where health systems are weak and services are largely centralized. Next slide, please. So why is this important to therapists? Well, in the bigger picture, how we respond now will determine our health outcomes and professional future later. Universal health coverage is centered around the principles of justice, equity, and efficiency, and the challenges faced by vulnerable populations should be balanced against the best use of available resources when designing people-centered services and responses. Recessions and austerity measures can worsen inequality and hurt the poor and the most vulnerable the most. Although local responses to the immediate crisis will differ based on context and resources available, a more coherent strategy is required for the medium and long term. Next slide, please. South Africa experienced an early, swift, and extreme lockdown, which continues to date. Unfortunately, the stimulus package announced to buffer the socioeconomic effects of lockdown in the form of welfare grants and food parcels was slow to materialize, and key social support services reduced to skeleton staff, freezing critical services such as new disability grant applications and identity document applications. Existing grant payments were centralized, further exacerbating out-of-pocket expenditure by the rural poor in accessing the payments. The crisis was viewed in the light of a medical one requiring a health response. The informal sector was shut down, and a large majority of the population found themselves without access to food or income overnight. This was made worse in the rural areas where families normally surviving off 1 or 2 welfare grants suddenly had to support double or triple the number of people on the same income, as migrant workers rushed back to their extended families in the rural areas. Civil society, including many healthcare workers and disabled organizations, responded admirably with soup kitchens and food parcels, but were simply unable to meet the overwhelming need. Severe restrictions in movement, in addition to socioeconomic hardships, impacted people's access to care, and this readily reflected in our Sentinel programs such as TB, HIV, and childhood immunizations. The school nutrition program, feeding over 9 million scholars, was shut down. The price of a basket of basic staples rocketed by 20%. Food insecurity rose exponentially, as did gender-based violence, child abuse, and mental health issues, including suicides. Again, why is this important? As therapists, we understand that before you can move forward with rehab, you first need to win heart and soul. Psychosocial support is a game changer. We also know all too well the pressure that food and financial insecurity place on families' mental health, priority setting, and abilities to access and remain in care. We understand the inextricable link between poverty and disability. Hopefully, we've made the link between poverty, social determinants of health, and health outcomes. Next slide, please. Overall, it is a humanitarian crisis fueled by a delayed and limited government response to a strategy which had the best intentions. It's always in hindsight that we can suggest a better approach, and one can only hope that these issues are addressed before the next crisis occurs. For the formal sector, including government services, this unfortunately fell at the end of the financial year, which caused even more disruption to an ailing supply chain, including the procurement of assistive devices and spares. The responsibility of prioritizing services and redeploying staff fell largely on local institutional and line managers, which prevented a coherent strategy across the regions. Metropoles with their tertiary and central hospitals were overwhelmingly affected, whereas rural areas experienced a delayed and often muted outbreak. Being at the discretion of the institutional managers in highly different contexts, and with varying levels of service development and capacity, and in different stages of the pandemic, a variety of rehab responses to the pandemic and subsequent lockdowns were experienced. Because of the heterogeneity, 2 response cases have been selected, a large central teaching hospital and a small deep rural rehab team's responses. Both responses, although very different, reflect the need for strong team cohesion and a health systems approach. Next slide, please. The teaching hospital employs over 3,000 staff and is situated in a major metropolitan area, which has borne the brunt of the COVID pandemic. With most rehab services at district hospitals and community health centres having been redeployed at the institutional manager's discretion to assist with tracking, tracing and testing services, and with outpatient and community services having been halted, the bulk of the acute rehab services fell on the teaching hospital's rehab team. Physios took on a large amount of the acute care and pulmonary work, whereas, for example, the OTs took responsibility for non-COVID related conditions. The transdisciplinary approach was critical, given the pressure on the health services and the need to reduce the length of stay. A swift and safe discharge is a huge challenge where contact with families is limited to telephonic conversations. This is still a country where a smartphone with data is a luxury, and basic needs including food, shelter, and care are not a guarantee. A departmental cell phone was acquired, and a centralized discharge database, including responsible therapists per client, was created. Patients and their families were given the departmental cell phone number on discharge, as well as extensive pre-developed home programs, and told to contact the department with any queries or problems. This seems to be working. The occupational therapists also allocated themselves to wards to assist with non-clinical duties such as procurement and IPC checks in order to relieve clinical staff of these duties. They also coordinated the staff wellness program, including organizing counseling and debriefing sessions online with clinical staff and councillors, and headed the risk mitigation committee assessing and redeploying health workers who are at higher risk to lower risk work areas. As lockdown eased, they allowed for the critical outpatient consultations such as tendon repairs, advanced seating reviews, and work assessments for essential staff. Next slide. The rural rehab team is experienced, well-equipped, has significant community networks and services in place, and has support from the institutional management team in continuing to focus on the needs of people with disabilities within the context of the pandemic. The rural area in which the team is situated has seen a mere handful of cases since March, as a functioning traditional authority and intact social structures. PPE is in short supply, and strict protocols around risk management, selection of PPE, and the reuse exist universally for all staff. A health professions WhatsApp group has been established, and daily meetings between unions, management, and sectional representatives are held. The team works closely with community health workers, municipal councillors, traditional authorities, NGOs, and faith-based organizations, as well as donor-funded DPOs and peer supporters. The team initially embarked on team strengthening as well as amalgamating 4 separate disability program databases and allocating each patient with an overall priority rating. Ward sessions at the district hospital continued without pressure to discharge early, but outpatient services were initially restricted to critical cases and then opened up as lockdown eased. Early intervention screening services were shifted to telephonic consultations with caregivers. Moderate and severe disabilities seen across all programs and service areas were prioritized according to need, and rehab services shifted to home settings, which ensured that the social stresses were appropriately identified and addressed, and rehab interventions were orientated to goals and context. This required upskilling of junior staff, a transdisciplinary approach, and embedding 2 rehab outreach teams in the existing institution's COVID community screening and testing initiative, because this ensured sustained access to transport for rehab outreach. At home visits, all members of a homestead were educated on COVID and screened before commencing with rehab interventions, and these were kept outside, as directive and hands-off as possible. The team also engaged in fundraising initiatives for food parcels for a local faith-based organization to cover families experiencing extreme food insecurity, including those without documentation. The peer supporters shifted their community services from home visits to telephonic and were able to successfully alert the rehab team about impending crises in the community and even averted readmissions. Disability support groups were mobilized to sew cloth masks to sell at a profit. With the procurement system severely disrupted and hardware stores closed, the team set about recouping and refurbishing as many assistive devices as possible, using whatever spares were available. This even involved asking community businesses to leave items outside their gates that could be used to repair and construct assistive devices for the head therapist to collect on her motorbike on the way to work each morning. The team is so satisfied with their approach that they're going to maintain it after lockdown ceases. Slide 8.
Marike, can we go to the implications for the future?
Sure.
Great, thank you.
There is no perfect response. No 2 teams are the same. No 2 contexts are identical. There may be aspects of each approach that could be adopted and adapted in different settings. COVID is giving us the chance to reevaluate our standard approaches to care and the values and objectives we have based them on. It's forcing us to work more efficiently with fewer resources. It's forcing us to strengthen our existing teams and our health systems, to work transdisciplinary and systematically, to place emphasis on self-management strategies and psychosocial support. It's forcing us to see the value in intersectoral approaches and truly appreciate mid-level workers, strong community, and disability networks. The next decade will be particularly challenging for everyone, and the cracks in the systems and services and the sheer magnitude of inequality have been laid bare. It's time for an honest and pragmatic conversation about the future strategy for the sustainable and equitable development of disability and rehab services. Thank you.
Thank you so much, Marike. Wonderful overview. We need to move on really, and it is a pity because each presentation could be really 1 hour of discussion, but thank you. There is a lot of comments in the chat box, so please also address any questions or comments that are coming from there. We need to move on to the perspective of physiotherapists, and Nihat Al-Masri will present. I'm actually bringing the perspective of Jordan, but also the perspective from pediatric rehabilitation. Nihat, you have the floor.
Yes, thank you so much. It's really my pleasure to participate in this webinar. It's very important, and I'm pleased to be speaking on behalf of the World Physiotherapy. As most of you know, the World Physiotherapy is the international representative body for physiotherapists all around the world. And today I'm participating to share our perspective related to how do we respond to COVID-19 pandemic with focus on low middle income countries. Next slide, please. So just to shed the light that we recently had changed our brand name from World Confederation of Physical Therapy to the World Physiotherapy to respond to the diverse experience of the global physiotherapy profession all around the world. Next, please. The previous one, please. Thank you. In March 2020, we know that the World Health Organization had declared the outbreak of COVID-19 to be pandemic. As the WHO and the public health authorities around the world have been taking action, also the World Physiotherapy was thinking about how to support physiotherapists in their act against the COVID-19 all around the world. We know that most of the people have mild forms of COVID-19, but still we have around 14% as estimated who present with severe acute respiratory infections and they require hospitalization. And we know that 5% of those people might be admitted to ICU. At that time, we had so many unknowns about COVID-19, more than what we know. But since that time, the world countries have started to look for and provide more information about the virus to guide the response to the pandemic. Next, please. So the World Physiotherapy have prepared tremendous amount of material and resources for information in response to outbreak, starting from our realization that physiotherapists have faced many challenges in their positions as academicians, as clinicians, as policymakers, and researchers. All of those had to respond to COVID-19 to the best that they can. Therefore, we have acted in providing, in addition to the World Health Organization material and the material all around the world, we provided a material to support campaigning to provide personal protective equipment for physiotherapists who are in front line of working with COVID-19 in ICUs and acute care setting. We also produce many briefing papers explaining the role of physiotherapists in providing rehabilitation services for patients with COVID-19, as my colleague mentioned before, during acute, subacute, and chronic stages. We also produce many resources and guidelines, and of particular interest, the educational resources that was provided for the educators to help them because they were teaching the physical therapists, and this pandemic has to be responded for. So in addition to all of that, we also started the registry that provided a tool to track activity and promoting collaboration and avoiding duplication efforts across physiotherapist organizations. We also provide regulations that was needed at that time to respond for the telerehabilitation services. Next, please. So mainly of particular interest are two documents that really helped us in low middle income countries to act against COVID-19. One is the document that outlines the recommendation for physiotherapy management in acute hospital setting, and it came as complementary to the WHO document. This included recommendation for physiotherapist workforce, not only to how to work with patients, but also to plan and prepare and to determine the requirements for physiotherapists. So we don't put our physiotherapists in front of COVID-19 patients without need. We also had many recommendations provided to them on how to select physiotherapy treatments and a lot about personal protective equipment. The target was to cover physiotherapists and support them, and in addition to other relevant stakeholders, of course, in acute care setting who are caring with adults, patients who have suspected or confirmed COVID-19. The second important paper that I want to shed the light on came due to the quarantines and the social distancing measures. Many health professionals have adopted a telehealth and telerehabilitation procedures. We don't have a lot about these systems, like telerehab in low middle income countries. So the World Physiotherapy tried to provide regulations to ensure the continuity of care for the patients using this new model of services. And in our opinion, this might be used only during the pandemic, and in other countries, it might be extending and used even after the pandemic. Next slide, please. So there are also other briefing papers that was downloaded by thousands of people all around the world. Here, I would like to shed the light on our experience in Jordan as a high middle income country related to how rehabilitation services were managed during the pandemic. In Jordan, we had an early conservative procedures. Lockdown, social isolation was taken as first measure. We're proud that maybe we have the fewest number of deaths across the area. This all limited the spread of COVID-19. Yet, in my opinion, the medical system at that time did not integrate rehabilitation services as an important measure for patients with COVID-19 for many reasons. Maybe because, as most of us realize, acute care physical therapy is not really a strength point in our part of the world. So for non-COVID-19 cases, in addition to COVID-19 cases, these resources came to support physical therapy practice in this setting. In my opinion, it's of utmost importance that our countries, Jordan, as well as low middle income countries with limited resources and great challenges, come to realize how important rehabilitation services are and to improve patient outcomes and quality of life. Healthcare systems at this time They are overburdened with patients who need rehabilitation services. So it is perfect timing to emphasize revision of policies and regulation to integrate rehabilitation in general and physiotherapy in particular in primary care setting, in acute care setting, as well as in ICU. And not only this, also to provide training for physical therapists to practice in these settings. We also need to support the tele-rehabilitation and digital rehabilitation services, because in my opinion, this might provide the healthcare system by supporting system to improve access and decrease demands on the rehabilitation sector. But this needs regulations, and it needs to be studied well and provided within clear regulation in each country based on each country pandemic status. Now, in response to COVID-19, many low middle income countries have been revising their health policies and regulations and seeking support and empowerment to face the pandemic. Therefore, it's perfect timing, as I mentioned, and as we think in the world physiotherapy, to support rehabilitation sector and to emphasize the Rehabilitation 2030 call of action that was released by the WHO in 2017. Next slide, please.
We need to move
on. Okay.
And it is very clear, your next slide, so that you are...
Yeah, I'm almost done. So this is an example of some of the advocacy camps that we supported the different countries through. And next slide, please, the last one. We have a full amount of information to advocate for personal protective equipments for physical therapists. And we're proud to be supporting many countries in their advocacy for this to happen. So I refer you to the website. The last slide, please. I refer you to the website for all the information, and I'll probably be happy to answer questions at the end. Thank you so much.
Fantastic. Thank you. Thank you for that. And thank you also for keeping us more or less in time. So let's move on. Last but not least, Francesca Gimigliano, who will present the perspective of the International Society of Physical Medicine and Rehabilitation. Francesca, you have a challenge, because we need to finish as much as possible punctual. So if you can keep it on time, that would be fantastic. Otherwise, we will lose the listeners. Please go ahead, Francesca.
Thank you, Larkus. I'll do my best. So as you probably know, ISPRM is the International Organization for PRM Physicians. It was founded in 1999, and it now counts 76 national societies and more than 40,000 members all over the world. Next slide, please. In terms of COVID-19 response, ISPRM has prepared some website resources and is collecting resources coming from journals, but also from, for example, WHO. And in this resource center, you can also find a forum where physicians or other associate members to ISPRM can actually exchange experiences, ideas, in papers on rehabilitation post-COVID-19. The next slide, please. Moreover, we have organized a series of webinars. And in the next webinar, Alarcos has given us the pleasure to be our host and speak about the collaboration with WHO and COVID-19. And in the previous webinar last week, we had the experience from a physician from Ghana and another physician from Saudi Arabia. All these webinars are recorded and are available for listening in our website. The next slide, please. As in general, it has already been said by the previous speakers that the population in need of rehabilitation in these COVID-19 times actually is somehow doubling, because on a side we have all those people who are experiencing disability and are in constant need of rehabilitation or are in need of rehabilitation at the moment. On the other side, we have COVID-19 patients who may need rehabilitation according to the severity of their symptoms. And we have a third population, which is non-COVID patient, that usually wouldn't need rehabilitation, but due to lockdown, that would mean activity limitations and participation restriction will now become in need of rehabilitation as well. Next slide, please. And these are some issues that somehow has already been pointed out by the previous speakers, divided for the different settings. And I'd like to point out a few one of them about the whole post-acute rehabilitation units, because one of the major challenges that have been seen from colleagues worldwide is it not only the fact that we are facing the consequences of a new disease that affects many organs, but also the fact that many rehabilitation units has been transformed in COVID units, and or has been forced to admit patients coming from inpatient units that needed space for admitting COVID-19 patients. And another point that was already pointed out by Pete was about the situation of outpatients, because there was a reduced access during the lockdown period all over the world to outpatient clinics. And at least here in Italy, where we are now have opened everything, we are in the situation that we have an overbooking of outpatient treatments that we have to give in a limited amount of time, and with the limitations that we have to apply to avoid risk of contagious. And another thing is that there is the fact that we still don't know everything about the long-term complications due to COVID-19. Another important setting has been home, and in home you can go to the next slide if you want. It's we have tried to all over the world. An hot topic has become telerehabilitation, and this is probably not for the best in general, but as it has been said also by Pete. In my opinion, it can be used to complement and enhance the quality of current rehabilitation services. Also, not only for COVID-19, in this period of COVID-19, but also for those patients who physically cannot access the clinics due to their disability or to the travel restrictions. And last slide, please. No, it's not the last, sorry. I just want to say a few words about the educational issues, because in this period, many things have changed, not only for PRM residents, but also for medical students and for rehabilitation health professional students, because many internships have been suspended, and many PRM residents have been asked to rotate in different divisions, in different units, including COVID-19 units. And so all the general educational program had to change. Next slide is about research. Research for COVID-19 and rehabilitation on PubMed, we find over 500 papers, because there has been a great effort from the editors and reviewers to try to do their best to fast track all COVID-19 papers. But if we limit the search to clinical trials and randomized controlled trials, we only find few results. So there is really need for high quality research. And my last comment would be that as a clinician, I would continue promoting somehow telerehabilitation, because this can become useful also in non-COVID times. As a teacher, as a professor at university, I would advise my students to try to take advantage of this situation, this emergency crisis, to learn as much as they can. And as a researcher and as the president-elect of ISPREM, I think that in research, the major challenges now are to collect data about functioning of COVID-19 patients, and to try to organize international clinical trials to implement research in rehabilitation in this patient population. Thank you very much.
Thank you for that, because you made it, huh? You really kept us on time. And look, unfortunately, and I have to apologize, unfortunately, we will not have time for discussion going back to your answer as questions, but be reassured that we will send some information collected, not only the slides, but also coming from these questions. What also this really emphasized that we need to do it again. It was the presentations were far too rich and needed to be discussed, and actually it needs to be brought to a next level, because one of the things that we also see, exactly the same, like it is being said in some of our comments in the chat, is still, despite of really seeing that during COVID-19 there is a huge need for rehabilitation, still it is very difficult to convince decision makers to invest in rehabilitation. So we need also to have a discussion on that, not only what is the situation, what is the response, what can be done, but also how we bring all this momentum to a higher level so that we also get the buy-in from policymakers and people making decisions that it is worth to invest in rehabilitation. I stop here. Thanking all speakers. It has been fantastic. Thank you for all your input and insight. And we from WHO look forward to more. I hope you too, you will hear from us. Thank you so much.